Members, this is the appointed time and we have a quorum. I'll call the meeting to order. Agenda item 1. Information papers issued since the last meeting. They have been set out in the agenda. Agenda item 2. Items for discussion at the next meeting. CB4 413/2023 bracket 01. The list of outstanding items for discussion and paper CB4 413/2023 bracket 02 list of follow-up actions. Our next meeting is scheduled to be held on the 9th of June, a Friday, at 10:45 a.m. The administration proposes the discussion of first, update on tobacco control measures, and second, update on enhancement of elderly healthcare voucher scheme. If there are no comments, then these two items will be discussed in our next meeting. Agenda item 3. Specialist outpatient clinic services, elective surgeries, and examinations at public hospitals. Paper CB bracket 4 413/2023 bracket 03. Please invite the representatives from the administration to join us. Members who wish to speak, please press the request to speak button. I welcome Dr. Libby Lee, Undersecretary for Health, Dr. Michael Wong, Director of Quality and Safety of the Hospital Authority, Ms. Ellen Chan, Principal Assistant Secretary for Health, and Dr. Jeffrey Lai, Chief Manager of the Hospital Authority. Undersecretary, please walk us through the paper. Thank you, Chair. Chair, public healthcare services are the cornerstone and population-wide safety net of the healthcare system in Hong Kong. At present, public healthcare services are mainly provided by the HA. The HA manages 43 public hospitals and healthcare institutions organized into 7 clusters based on geographical location. Other than primary healthcare services, comprehensive secondary and tertiary medical services are provided, including accident and emergency services, acute and infirmary inpatient care, specialist outpatient service clinic services, and other non-urgent day surgeries. For secondary health care, we provide more complicated cases, and patients are triaged according to their conditions into the categories of urgent case, semi-urgent case, and stable case. Patients may be arranged to accept treatment or services such as radiography, imaging services, etc. For specialist outpatient services, the number of attendants is now reaching 8 million. Because of a shortage of manpower for medical staff, the waiting time of patients is facing enormous stress. There are many factors at play when it comes to the burden on public health care. One of the factors is that we need to enhance the triage of patients. For example, a patient may have 2 specialist appointments which can be turned into 1 appointment at internal medicine, and some follow-up cases may be referred to family doctors, and there are some surgeries that can be done in the form of day surgeries to reduce pressure on manpower. The primary healthcare blueprint was promulgated in December 2022. It shifts the center of gravity of our healthcare system from treatment-oriented, institution-centric, secondary, tertiary healthcare to prevention-oriented, community-centric primary healthcare. And in the long run, this can ease the pressure on secondary and tertiary healthcare. At the same time, the Hospital Authority has kept a close eye on the mode of services provided and try our best to enhance these measures. to shorten the waiting time for patients to better cater to their needs. To improve or to shorten the waiting time, the HA has adopted the measure of narrowing upstream, collaborating downstream, and diverting midstream. Narrowing downstream aims to relieve the pressure on SOPCs through management referrals and to utilize family medicine and other specialties to follow up on patients' cases. Diverting midstream aims to provide appropriate triage of cases referred to SOPCs for strengthening service support through various means. New cases may be referred to another suitable SOPC in the same cluster to balance the distribution of service. And this can help healthcare professionals to provide appropriate care to patients in a timely manner. Collaborating downstream aims to review cases of recovered and stable patients for appropriate arrangements. For example, these patients can be referred for follow-up action in primary healthcare services providers. And patients may choose to seek primary healthcare services at the community level. This can free up resources for other patients in need. In order to monitor the waiting time for SOPCs, in his policy address, the chief executive set targets for the waiting time of internal medicine. This is the first time that a key performance indicator has been set. In 2023 to 24, the target is to reduce the waiting time by 20%. That means the waiting time is to be reduced from 122 weeks to 97 weeks or less. 97 weeks is still a long period of time, but this is a step in the right direction. And lately, the waiting time for stable new cases for internal medicine is 102 weeks. That is the 90th percentile. The policy address also put forward streamlining the workflow of patients attending medical consultations as SOPCs. For the target is that 75% of patients can complete the process from registration to consultation within 60 minutes and complete registration to medicine collection within 120 minutes. The latest figures show that these targets have been achieved. Regarding elective surgeries and examinations, the HA has been adopting a multi-pronged approach to improve the waiting time of relevant services. We have stepped up the relevant manpower, prioritize surgeries, adopt high-volume surgical model, promote non-surgical treatment, enhance manpower and equipment needed to cater for the needs. And private-public programs have been rolled out to cater to the needs of patients. The HA consider the needs for various specialties and whether or not primary healthcare services will be able to take over the cases of stable patients. In the face of the increasing demand for specialist services, the current mode of service provision is not sustainable. We want to help patients to start from prevention of diseases. We hope that we can roll out the program of one patient, one family doctor. These cases can be followed up by family doctors, and more complicated cases can be referred to specialists. At the same time, the government will monitor the HA in the review of the current service provision mode in order to enhance efficiency and to shorten the waiting time for patients. And specific performance indicators will be set to meet the service needs of our society. Thank you, Chair. Currently, we have 7 members wishing to speak. Mr. Kingsley Wong, Professor Chen Kwong, Dr. Dennis Lam, Dr. Priscilla Wong, Ms. Rebecca Chen, Mr. Siu Kafa, and Dr. David Lam. 4 minutes each. Mr. Kingsley Wong. Thank you, Chair. In paragraph 10 of the paper, we can see that there is an increasing demand for SOPC services. There are 8 million patients attended with about 900,000 new cases every year. The waiting time is very long. As I understand, some patients have been waiting for 5 or even 7 to 8 years for a consultation. Many patients who couldn't afford to wait went to Guangdong province to seek medical consultation, and it cost them $27,000. This shows that resources on healthcare is in a shortfall in Hong Kong. Can we introduce innovative thinking to solve this problem? Can we arrange specialist operations to be conducted at the HKU Shenzhen Hospital? Can this be a way to solve our problem at hand? Can you answer this question for me? In terms of skills, the standard of services is certainly good at the Hong Kong U Shenzhen Hospital. And in terms of financial concerns, it is certainly cheaper than that in Hong Kong. So can the government tell us this? Is it possible for patients who couldn't afford to wait any longer to conduct their specialist operations at Hong Kong U Shenzhen Hospital? Or if it is effective, can this program be expanded to other Grade 3A hospital on the mainland? Thank you. So what you mean is we should refer the cases to the Hong Kong U Shenzhen hospitals and that the expenses are paid by the government. Is that correct? Because if they are waiting in Hong Kong for 5 to 7 years, then the government has to pay for the operations as well. Yes, that is true. Thank you, Chair. Thank you, Mr. Wong. Our services in mainland mainly target Hong Kongers who reside on the mainland. What you have just mentioned is to purchase services on the mainland. There are a few factors that we need to consider before proceeding. First one is whether or not the patients are willing to accept services there. Second, the interface of services. Third, the quality of services. We need to ensure that they provide quality services before we can allow the public to receive services there. There are also other concerns in terms of surgery. There are rehabilitation services required before and after the surgeries as well. Let's say for joint replacement, it takes a few weeks of rehabilitation. We need to look into whether or not this is feasible. But I believe that we can still handle the situation with the public-private partnership programs. What's important is for the HA to step up manpower and enhance efficiency. Undersecretary, the question raised by Mr. Kingsley Wong is regarding patients who have already been waiting for 5 to 7 years. That is a very limited scope. For these patients, is it possible for them to have their surgeries elsewhere, let's say in the Hong Kong U Shenzhen Hospital? Perhaps you can relate this message to the Secretary. By adopting this method, perhaps you can even save money for Hong Kong. If patients receive these surgeries in a private sector, perhaps it will take some $100,000. I'm sure it will be cheaper to do it in the mainland. Thank you.
Professor Chen Wing-kwong, Chairman, thank you. I'm glad that the hospital authority is trying to shorten the waiting time. My question is for specialist outpatient clinic in 23-24 for the stable new case, the waiting time will be reduced by 20%. The government is trying to adopt the narrow upstream, collaborate downstream, and divert midstream strategy. But given the tight manpower supply, to achieve the policy address objective is going to be really daunting. Is the HA confident that this will be achieved? How are you going to shorten the waiting time, and how can you make sure that this will be balanced against the preservation of quality of service? And second, in terms of manpower shortage, this is really the culprit for the long waiting time. To shorten the waiting time, the ultimate solution lies with the replenishment of the manpower. We have 8,000 or so registered TCM practitioners, and I hope that the government will utilize this particular dedicated team for the medical care services, and we can make available all kinds of medical services. This will contribute to the reduction of the waiting time. This will also assuage the pressure on the healthcare sector, and 8,000 TCM practitioners can also render their service to the members of the public. This is many birds with one stone. I hope that this will be taken into account. And the Secretary, I defer to Mr. Lai for one of the questions. I will address the TCM issue later. Dr. Lai? Well, this is indeed dear to our heart, and manpower is very much the issue. So we are sourcing or identifying manpower from many sources. And in the upstream, downstream, midstream, we do have many measures to address the issues. Like at the upstream, we can control the referral of cases. We have to make sure that it's only the genuine cases that will be admitted to the system. And also, we have the integrated clinics that will be offering treatment to the patients first. And in relation to the quota, we will fully utilize the daily quota in a way that the quota will not be going to waste. And for the downstream, we will be fully utilizing the primary health care. We do have the PPP scheme. There is the private sector market. We have the PPP system to handle the stable cases. Given the finite resources, we are utilizing the resources to handle the waiting time that way. In the past year, we've seen that for internal medicine, the stable new cases, the waiting time has seen some improvement from 120 weeks to down to 102 weeks. We are going to be stepping up these measures to achieve the objective. Under Secretary, TCM, Professor Chen must be aware that the TCM is an important component of the healthcare system, that there's going to be a blueprint. What we like to emphasize is that the TCM can render assistance at the primary care level. There will be more discussion going forward. Any follow-up? No? Dr. Dennis Lam, Chairman, declaration of interest. The company that I serve is providing healthcare services in Hong Kong and also in the mainland. I also like to focus on the specialist care. I heard a moment ago from the HA and also the Bureau that a lot of efforts have been put in and many measures are putting in place. I like to congratulate them on this. But in terms of the effectiveness, I think it would take time for these to be yielding tangible results. I'm not terribly optimistic about it. Two basic questions, if I may. For the specialist doctors in HA, how can we ramp up the efforts to guard against wastage? And also identify more sources of doctors for replenishment. Now we're talking about introducing the dentists, non-locally trained dentists, when introducing them to Hong Kong. But what about specialist doctors? Can we come up with some ideas. PPP, indeed, we are doing this, but are we going far enough? Mr. Kingsley Wong made the point that the cross-boundary procurement of healthcare services, now we have the services from the Shenzhen Hong Kong U Hospital. There are other healthcare organizations that are providing quality services. So in terms of PPP, we should ramp up the efforts. We should identify more sources of specialist doctors who are coming from outside. I defer to Dr. Wong. Chairman, thank you. Yes, about the retention of specialist doctors, the HA has been proactively retaining doctors, and we're also recruiting new specialist doctors. As you are aware, we are going overseas in order that the new graduates are willing to come practice in Hong Kong under the special registration or limited registration scheme. Now, we paid a visit to the UK recently, and from that, we have received quite a lot of inquiries. The response has been pretty good. And the retirement age of doctors is gone up from 60 to 65. And there are many doctors who are prepared to continue on after retirement, and that would replenish the manpower. And we're also recruiting locum doctors into the rank. During COVID, there are some locum doctors who have joined the HA to render the service in various departments. And there are 300 locum doctors in this regard. In order to retain doctors, we have arranged for more promotion prospect. We have increased the position of associate consultant and consultant posts. We also have the mortgage loan scheme in order to instill a sense of belonging and also retain the talents. Other than retention and recruitment where appropriate, we also have the special honorarium program, and we can also replenish the doctors there. We also emphasize the importance of training. A lot of the overseas training has stopped because of the pandemic, and this has been done online. But with the receding pandemic, we will be sending doctors for overseas training in order to equip them and enable them to, or incentivize them to continue to serve in the HA. Undersecretary, yes, about PPP and also the services available at the GBA. A couple of weeks ago, we have the pilot scheme. The HA patients can receive medical care at the GBA. This is a pilot. There is going to be a review to see whether this can be broadened out to cover more services in the mainland. Dr. Priscilla Leung. Chairman, thank you. The quality of service at the HA is really good, so much so that a lot of people are attracted to the HA services for the outpatient services. When they are making arrangement for the services, I think they need to look further ahead. There are many people who emigrated overseas in the 1980s. They're senior citizens. They're coming back to Hong Kong to queue up for the medical care in Hong Kong because the insurance package doesn't cover their presence in overseas countries. What about in Hong Kong? Now let's brush aside these immigrants. I'm not sure whether you have the numbers. In 2034, those above the age of 65, it would take up 1/3 of the population. The population of young people will be inexorably declining. Now, this is a really pressing problem. And what you are doing is really fragmented. You are allowing some more rest time for the doctors. This is not a good enough measure. We're not suggesting the doctors should be made to work exhaustively. We want more measures. We trust that the HA will come up with a more comprehensive package. The Undersecretary has really tried her best to address the questions, but she has been beating about the bush. In terms of the GBA and the outpatient clinic and also the surgery, things are really wonderful. I've got a friend, he can have the surgery performed on the kneecap on an emergency basis. It was done in a very short period of time. If you do not improve the manpower, it would be hard for you to go any further in the way of PPP. I've raised this at the NPC, and people don't have to come back to Hong Kong for the surgery. Now, you can ask the secretary. The Shenzhen hospital service is pretty good. There is a high level of trust. Hong Kong people are patronizing this. I think that you should broaden this kind of service, not just one. This is indeed a pressing problem. 5 years down the line, when I put this question, you will be really overwhelmed. Well, she may not be here. She wouldn't be worried. Undersecretary. Thank you, Dr. Leung. We talked about how we can take full advantage of the resources, albeit the mainland hospital resources. Now, there are some pilots. We have the outpatient clinic during COVID. We've done something also. Can this be expanded? The Policy Bureau is looking at this to see what hospital, what services can be provided in a collaborative manner. We will certainly look into this. This represents a way forward. Dr. Leung, will you give us a number? I'm sure you must have the number. For those over 65, this is a pressing problem because at 65, they can't afford the insurance premium. A lot of the medical care will be coming to an end, and they are registering to take medical to patronize the hospital authority when they hit 65. In Canada, they have so-called the free medical care, and many of the senior citizens or many people who emigrated in the 1980s, 1990s, or 20 years ago, and they are getting on a bit, coming back to Hong Kong for the medical service in Hong Kong, where they're queuing up for that. Ms. Rebecca Chen. Chairman, thank you. First of all, for the hospital authority, those who are working on the front line and also in the middle rank, they are working really flat out, and we're grateful to them for that. The front line officers are on the sharp end of the issue, and I am unhappy with some of the management there. We're talking about the specialist outpatient clinic services, elective surgeries, and examination. Have we ever heard of the waiting time being shortened? It will only get longer. We are devoting more resources, but the queue is getting ever longer. Now, you're not doing a good job in this regard. Now, we have the flu surge, and that there is also an upsurge in COVID. I know that the A&E has to cope with the emergencies. Can the hospital authority think out of the box? Now, there can be mobile medical vehicles. They don't have to go to the A&E. You can deploy these kind of mobile vehicles to cater for the flu patients. Now, from the paper, I know that you are working very hard. Now, you said that you are trying to make sure that things are being done. In the KPI, I mean, there are KPIs in the policy address. There are 5 top-ranking officers. You are earning more than $5 million, $6 million a month, far higher than the secretary, far higher than the chief executive. I can't see how you can shorten the waiting time in any way. Like you have the co-management scheme and so on. The hospital authority services are really good in quality. They're not expensive. Now, for those who are using the specialist outpatient service, why would they go to the private sector? Would the private sector be charging as low as you are? Are you able to triage and divert some of the patients to the co-management plan. Is there any collaborative model? Now you have the cataract PPP scheme. This has been around for 20 years. Are you going to provide new services that will be sufficiently attractive?
Second, regarding the hospital of the HA, well, there has been some trouble with the HA facilities, and you can't keep up with the number of patients under the influenza season. Our grassroots and patients are suffering because of this. Oh, first, I'll invite Dr. Wong to take your questions. Thank you, Chair. Under the co-care service model, stable patients who have regular consultations with the SOPCs, they will be referred to doctors in the private sector under this model. The cost is approximately the same. The rest will be subsidized by the government. So in terms of the cost borne by the patients, there is not much difference. It may actually facilitate them because they can go to doctors near their homes, and they may be doctors that they are familiar with. So this is actually beneficial for patients. Chair? So that means you are diverting the patients to the private sector, is that right? Then the waiting time will be reduced. Then how come the result is like this? Well, it would be best to attend the private doctors. Then how come the waiting line is still so long? Does that mean that services provided by the private sector is not enough? Under Secretary, on HA's performance and efficacy, yes, we are concerned about them. The government has provided substantial subsidy to the HA, so they are responsible for enhancing the service quality. So there is a committee set up to monitor their performance. There are representatives from the administration and from other stakeholders. We want to enhance their management efficiency. I understand that they already had a meeting, and the HA has been advised to manage their performance indicators. We hope that through this committee, we can enhance the performance of the hospital authority. Next, Mr. Siu Ka-fai. Thank you, Chair. A few days ago, a friend told me about the A&E services that he received. He said that he had stomach pain and he went to the A&E department at night, and he had to wait until 6 a.m. the next morning. He said that during this long wait, he returned home to have a meal. Then I asked him, well, didn't you have stomachache? How come you could still eat? Then he said, well, I was hungry. That's why I went home. Then I asked, that means your case is not that urgent, right? You could still have the appetite to eat. Well, I could see that he has returned to good health, but it shows that people have trust in the A&E services provided. For these non-urgent cases, they may take up quotas for other urgent patients. This may delay the services provided to urgent cases. But is it because the cost is attractive? Patients who suffer from colds, if they have to pay more than $100, perhaps the cost is closer to private doctors, then they may not go to public clinics after all. There may be not enough facilities And the fact is that we don't have enough doctors. I would like to know regarding the changes in the import of doctors. Is it possible that we can do more? Under Secretary, I'll take the first question, and I'll invite Dr. Wong to take the second question. You are correct in saying that many patients attending the A&E department may not be urgent cases. We will review the charges of the HA. It is true that it is not reflective of the inflation of society. And for many patients, they do not have the concept of attending family doctors. That is why in the primary healthcare blueprint, we want to promote this idea of going to your family doctors first. But there are things that we can do, that is to review the charges of the HA and review the manpower situation. Dr. Wong, as of 31st of March this year, we have 50 limited registered doctors with limited registration. After the legislation was passed, there were still many factors to consider for these doctors. It takes time for them to take various factors into consideration, and we've just come out of the pandemic. There were travel restrictions in place, so they may come to Hong Kong at a later time. According to our latest inquiries, the response has been quite positive. When we visited the UK, we actually received some 100 applications. Well, I've been told that in order to become a specialist in family medicine, it takes doctors 6 years of training. Is that necessary? We are in need of doctors who specialize in family medicine. Is it possible for you to reflect that or relate this message to the relevant authority? Thank you. Next, Dr. David Lam. Thank you, Chair. According to information provided by the government, in 2022 to 23, the average cost for each visit to the A&E is $2,080, and specialist consultation is $1,600. And for government general outpatient service, that is $600. That is higher than the average private sector consultations. According to the latest figure in 2022 to 23, the total attendees of healthcare services is 7.14 million, and new cases accounted for 741,000. So that means about 14%. So that means for every 9 old cases, there is 1 new case. So undeniably, this is going to crush our public healthcare system. Because for the old cases, if we provide 3 consultations for them per year, that will already be a lot. I understand that some of them have been referred to the general outpatient clinics. But appointments are quite full there as well. I understand that they can be referred through the GOPC PPP program. I understand that there is a trial scheme going on. I wonder if you have any timetable on the actual implementation and how many patients are we talking about? And other than hypertension, will other diseases be included? And realistically, for SOPC, it is very difficult for them to refer patients to GOPC. it is difficult to convince the patients. If you tell them that they can have a follow-up consultation, it may only take a few minutes. If you are suggesting a referral to GOPC, that may make issues more complicated. I understand that this is a concern of our patients. They are afraid that they cannot afford consultations in the private sector. So how can our colleagues better explain the situation to the patients? Under Secretary, on SOPC, I'll invite Dr. Wong to take that question. I would like to talk about the cost of the HA services. I would like to stress that this price covers the consultation and medication, etc. We are talking about 6 months worth of medication, so it is difficult to compare directly with costs of the private sector. I'll invite Dr. Wong to elaborate regarding SOPC. Thank you. Yes, we are aware of this problem, that there are far more old cases than new cases. So we need to triage them to the private sector as well. What we are doing is that senior doctors will review all the old cases. If their conditions are stable, then their consultation with the specialists will be terminated and they can be referred to GOPCs. As for the PPP, it has started already, but not for every specialist service. There are internal medicine services available, etc. We are trying to expand the service to other specialists. Once the patient is referred to the primary health care, their medical record is still with the specialist service, so it will not take long for them to get another consultation with specialists. Can I have a short follow-up? Well, time is up, but go ahead. Is it possible for you not to close the file on the patients, because this worries them a lot? We are talking about a matter of confidence. Thank you for your suggestion. We'll look into this possibility. Next, Mr. TIEN Puk-sun. Thank you, Chair. Well, regarding the approach of narrowing upstream, collaborating downstream, and diverting midstream, well, it was proposed back in 2019. Is this approach still applicable today? Do we need to review or enhance this strategy to maximize effectiveness? In terms of narrowing upstream, I can see that you are trying to limit unnecessary referral. You said that there are 900,000 new cases per year. So how many of these cases constitute these so-called unnecessary referrals? Chair, Dr. Wong will take the first question. The second, Dr. Lai. Dr. Wong. Thank you, Chair. Regarding SOPCs, after our colleagues receive referrals, they will categorize the cases into 3 categories. That is the urgent case, semi-urgent case, or stable case. For now, the majority of them are urgent cases. There may be some cases that do not require specialist care. I do not have the exact figure, but we believe that the narrowing upstream strategy will be able to intercept 10 to 20% of these referrals. Dr. Lai, regarding the narrowing upstream strategy, I don't have the exact figure on hand, but 30% of the referral come from the HA itself. I'm sorry, the internal referrals account for 70%, and referrals from the private sector account for 30%. We don't keep statistics on the percentage of unnecessary referrals. But in A&E departments, for example, there are senior doctors who assess the cases to see if specialist consultation or referrals are required. You can see that nearly half of the cases can stay in the A&E department or in the primary healthcare system. So that is quite a lot already. Thank you.
Mr. Chen, right, it's my turn now. You talk about cases. I'd like to cite a case as well. Now, he has a joint problem. He has been waiting for 7 years and hasn't got his turn, and he's got problem with his left hand side as well. And he raised $100,000 to get the joint sorted out. And I mean, it's been waiting for so long. I'm not sure how far along is his wait. Like members talked about identifying new sources of doctors. What you're doing right now may be steps in the right direction, but they're not fast enough. In the 1990s, we didn't allow the medical council to get in the way. The Commonwealth doctors could come and practice in Hong Kong, and we never ran out of specialist doctors in the public hospitals. Life was harder in the private sector because in the public sector it is not expensive, and there are no language problems because these Commonwealth doctors are English speaking. At the Finance Committee, the CEO of the HA said that we need Cantonese other than anesthetics, and we can also have the medical students who can become the translator. I think the government, not so much the hospital authorities, should really have a look at the importation of doctors. I said, as a first step, we can allow permanent residency to these doctors. I mean, I don't think I should say this, but I know that the hospital authority is working very hard to address the problem. But I can tell you that you will not get any more than 500 doctors in the first 5 years. And also at the Finance Committee, Special Finance Committee, I raised the point for the administration. There are many private doctors, and you might wish to tell them that you can come and work in the hospital authority for a whole day or for 2 days maybe, especially these specialist doctors. We can offer them some tax incentives. Instead of offering them $500, $600 per hour, they can't be remotely interested. There are some doctors who said to me that they would find this idea pretty interesting. The private practitioners are making a lot of money, and with tax concession, you don't have to dip into your pocket to pay them. If the FS find this agreeable, I'm sure that you will be able to identify many specialist doctors who are prepared to work in the HA, and the waiting time can be shortened as a result. And do the specialist doctors in the private sector have to work in the offices for 6 days a week? They can certainly set aside 1 day or 2 for the hospital authority. You don't have to address my question. I'm just suggesting that this can be a very good source. Under Secretary, this is a very good idea. We'll certainly consider that. As to whether we can consider non-local residents, we will consider that. We've gone over the time a little bit, and I think we can leave this item at that. Thank you very much for being with us, official. Next item 4, end-of-life care, legislative proposals on advanced directives and dying in place. There are 2 papers there, CB4 413, bracket 04, and also bracket 05, one by the administration, the other by the electrical secretariat. I'd like to invite the administration in. We have the Undersecretary, Mr. Eddie Lee, Deputy Secretary for Health, Dr. Sarah Ho, Convener Task Force on HA's contribution to AD legislation, Ms. Nancy Kwan, Assistant Director, SWD, Dr. Tzit-yuen, Honorary Advisor, Task Force on AD legislation, and also Dr. Doris J., Chairperson, HA Clinical Ethics Committee. We've gone over the time a little bit. Can you make it brief in your introduction? Chairman, in light of LRC recommendation, the government conducted consultation in 2019, and in July 2020, we published the report. In the light of the consensus during the consultation, the government is going down the legislative path to implement the recommendations and advanced medical directives and dying in place, respecting the decision, represent the main recommendations. Basically, a written statement is a person's indication what life-sustaining treatment he or she would refuse when he or she is no longer capable of doing so. There is no legislation regarding the legal status of AMD. Under the common law, with any treatment, we need to have the consent of the patient. So under the common law, the AMD is legally binding. Despite that, we haven't got the practice codified, and there is still uncertainties regarding this AMD business. So the government is has drafted the advance decision on life-sustaining treatment bill in order to regulate this arrangement. The idea is to codify the common law practice and offer legislative safeguard. Second, we remove the legislative impediments to the implementation of AMDs by emergency rescue personnel. Under Coroner's Ordinance, Cap 504, in the RCHDs and RCHEs, which are non-nursing homes, all these will have to be reportable cases. The requirement is an important safeguard for the residents of these places, but this would cause some resistance on the part of the RCHG. So we're going to be amending Cap 504 for death of natural causes. That if they measure up to certain requirements, they will not be reportable death cases. And we hope that the terminally ill residents in these institutions will choose to die in place. The government is drafting the legislation. We aim to submit the bill to the council in 2023, and regarding AMD and dying in place. Other than legislation, we are working very hard to take forward the life and death education and also the training and development of the emergency rescue personnel. We will implement all the whole package of measures to respect the patient's decision and to ensure the quality of life of the family members and also the well-being of the family members in this regard. There are 7 members who have pressed the button to speak. Mr. Chen Kim-puk, Dr. Tzit-yuen, Professor Chen Kwong, Ms. Connie Lam, Ms. Chen Hoi-yan, Mr. Peter Shiu, and Dr. David Lam. It's my turn. Yes, please, Mr. Chen Kim-puk. Well, this is a good piece of legislation, if enacted, because this can remove a lot of hardship and sorrow, and this will also minimize disputes. It's good for the rescue workers as well. Now, with the implementation of the AMD, all the difficulties facing the stakeholders will be resolved, the care homes and hospital and so on. I hope that the government will continue with its efforts. This is something that the government should be pragmatic about. I've got two questions. Would there be any central registry to record the AMDs? There are some suggestions that in the health record sharing system, there would be an entry there. Third, to make sure that there will be no third party fiddling with the AMD, will there be any particular requirement for the witnesses for the adoption of the AMD? Under Secretary. Yes, first about the central registry. For the second question, I defer to my colleague, Mr. Lee. First off, about the central registry. The whole idea of the AMD is to make sure that it is a cautious making and easy revoking approach. But at a certain point, if one were to revoke the decision, we hope that there will be a mechanism whereby people can revoke the AMD. This is the cautious making, easy revoking approach. Now, if you can imagine, if a terminally patient is at a late stage, he will be very weak and infirm, and if you have to check the data on the computer and revoke the AMD, it would be a really laborious process, would present difficulties for the patients. So having regard to this, we would still stick to the paper-based AMD. One can tear up or strike off the signature on the paper-based AMD. It would be easier for this to be done. I defer to Mr. Lee for the other question. Deputy Secretary. Yes, like the Undersecretary said, we have this cautious making, easy revoking approach. There are many ways to revoke the AMD. One can choose not to show the document, one can destroy the document, or one can screw up the document into a ball and to show that this has been revoked. And even for verbal revocation, there has to be a witness to provide the safeguard for the patient. You said screwing up the document into a ball, and that represents a revocation. Everybody can do that, but what does it mean? You burn it, I can understand that. Mr. Chen Kim-puk, I agree with you there, Chairman. I think you have to be careful on this one. The family members may be so sorrowful that they may tear up the AMD. I think we can have further discussion at the Bills Committee. Deputy Secretary? No? Dr. Tzit-yuen? Chairman, I support the legislative proposal regarding the advanced medical directives and dying in place. The welfare sector has been advocating these. There are some organizations that haven't quite finished with that, and the whole thing fell by the wayside because there is no legislative requirements. There are certain organizations that can't be bothered doing it. Now, you are going down the legislative path, and this is all for the good. With AMD, there is no legislation at the moment. If you codify that, certainly it would be a good step. And you're going to have the public education. During the consultation, there are many in support. There are more in support than against. The general public probably wouldn't understand this very well. When the patient is in critical condition and you need these kind of document, without any public education, it would be really hard for the stakeholders. So publicity and education would be necessary, and we also need to provide training. We mentioned the central registry. I do hope the administration will consider that. And you said you tear it up, you scrunched it, and you can render this invalid. That's because the way it is stored. I mean, if I keep with the law firm can fold and there can be confusion. I think if you have the central registry, that would be easier for you to adopt this cautious speaking and easy revoking approach. So I hope that the administration will seriously consider this. It doesn't cost much.
You can appoint NGOs to do that as well. That will not be complicated. Regarding dying in place, I welcome this arrangement because in the past this has caused the RCHE some issues. Because if we can make it clear the arrangements, I believe that will certainly be beneficial. And it is easier to explain to family members as well. They may inquire as to why they don't send the elderly to the hospitals. From our experience, we believe that this is the best option for the elderly because they can stay in a familiar environment. This has everything to do with public education. Under Secretary. Thank you, Chair. Thank you, Dr. Teck. We understand the importance of public education because we believe that for life and death issues, members of the public need to be aware of the issues involved, so education is important. As for the centralized registry, it is not a matter of cost. We are considering the benefits and its drawbacks. We want to stick to the principle of easy revoking. We want to provide an easy way for people to change their minds when they want to revoke their AMD. If there is a centralized registry, that may deter people from revoking their AMDs, but we will certainly consider that. Under Secretary, I hope you note that for the two members who have spoken, they hope for a centralized registry, and this is my opinion as well. I've heard from my personal experience, I've heard different views from my family members or even siblings. How can a person pass away in peace if you can't facilitate harmony among family members because there is no centralized registry? That may not be good for the HA and for the patients as well. Chair, I agree with you. I worry that there may be cautious making of AMD, but there will be random revoking of the AMDs. I don't think that your ideas are bad, but if there is a centralized registry in place for doctors, RCHEs, and for family members, they'll understand that the revocation is not to be done lightly. Thank you. Next, Professor Chen Wen-kong. Thank you, Chair. I support the measures of the administration to enhance the life quality of patients at the last moments, but I have some questions regarding the details. In paragraph 4, it is mentioned that since 2012, the number of AMDs made by HA patients has been on the rise. Do you have any specific figures regarding the number of AMDs made by HA patients? If yes, How is the public reception regarding AMDs? Second, if in the AMDs the patients expressly refuse treatment, but if family members refuse to follow these instructions, how can doctors strike a balance there? Third, copies of AMDs can be a valid proof of instruction. According to the paper, the patient can cancel or revoke the AMD at will. If they have decided to revoke the AMD but they have not destroyed the copies, how will the situation be handled? And how can doctors and emergency rescue workers verify the instructions in the AMDs? That can be quite difficult. Some other members suggested the establishment of a centralized registry. I find that is quite important. And will this be incorporated into the e-health system so that people cannot forge AMDs and that doctors can follow the patient's wish in carrying out medical treatment? And according to the paper, two witnesses are needed, and one of them needs to be a medical practitioner. He has to explain the nature of the AMD and the results of the AMD. So I wonder if doctors from the HA will undertake this task. I think we all know that there is a manpower shortage for HA doctors. Like what Dr. Lam just said, it may take a long time to explain to patients. This can affect their relationship and hinders the carrying out of their daily jobs. So how are we going to strike a balance there? Do you support the establishment of a centralized registry? Because you were just referring to views of other members. Yes, I support the establishment of it. Thank you. Under Secretary. First, regarding the AMD copies. Second, regarding how we can promote or implement AMDs clinically. I'll invite Dr. Se to take the second question. Our patient has time to consider the medical options before their last moments, so they can have discussion with their family members. When they set up their AMDs, they should already have come up with a consensus with their family members. I'll invite the Deputy Secretary to talk about the copies of AMDs. Thank you. We are drafting the details of the legislation. The copies are not just any copies. There have to be a certified true copies by professionals, such as doctors. Second, we hope to assign numbers to each of the copies so that the patient can remember how many copies there are. Then when they want to revoke the AMDs, they have to revoke all 3 copies if they have 3 copies in place. Next, Dr. Se. Thank you. We have been compiling statistics since 2021 regarding number of AMDs made by the HA. In 2011, there are 149 AMDs revoked. There are more than 1,700 in 2021. So over the years, there have been 11,000 AMDs signed by doctors. As per the guidelines of the HA, doctors need to have ample discussion with their patients. other than discussing it with the patients, they have to discuss it with family members as well. In Chinese society, we place great importance on family harmony and consensus. The AMD should be signed after this discussion. This is to minimize the chance of any disputes in the patient's last moments. So the element of discussion is very important. So which doctors signed these 11,000 AMDs? Well, there are a few specialist categories, such as oncology and palliative care and geriatric specialists, since they have a lot of elderly patients. These doctors need to carry out discussion with patients in need. This can minimize any disputes at the end. So that means HA doctors will sign AMDs, right, to answer your question. Well, members, we still have 5 members wishing to speak. This item should wrap up by 12:10, so that means 15 minutes left. So we will strictly stick to the time limit of 4 minutes question and answer. So if you can't finish responding to members' questions, please submit a written reply after the meeting. And members, please be succinct. I hope that we can finish this item in 15 minutes. Next, Ms. Lam So-wai. Thank you, Chair. Overall, I support the legislative proposals on advanced medical directives and dying in place. Many terminal patients or the elderly would like to be able to return home before they pass away. When they are mentally capable, they sign the AMDs and they do not attempt CPR note, so that treatment will not be carried out against their wish. To my understanding, there are some dying-in-place arrangements offered by palliative care. But the problem is, doctors in public hospitals cannot provide on-site services. So will these patients be transferred to hospitals in their last moments, and emergency workers may continue to offer treatment or CPR? This may be against the wishes of the patient. Is it possible to collaborate with some NGOs, with nurses and doctors of palliative care? In the final days, perhaps patients can sign some papers so that they can be taken care of properly, and that they don't need to receive any resuscitation in their final hours. And second, in their final days, patients require comprehensive care. Carers may need to bathe the patients, clean them, and take care of them around the clock. It is very difficult for one single carer to handle all these. So will there be any cross-departmental care or support services provided so that help can be offered to these carers to better take care of these patients in their last days? Will there be any collaboration between the district care teams as well? Thank you.
多謝。
And the Secretary, thanks very much for the question. And there are many districts where we have the NGOs and the private practitioners that are cooperating on this. If this bill is enacted, I'm sure that will facilitate this practice. If an AMD has been made at the A&E department, there will be no resuscitation because it is if this is the stated wish that this is the case, there will not be any resuscitation. But I'm sure that there would be more cooperation between the NGOs and the medical sector. We hope that there would be more coordination in the community. We'll certainly look into the possibility of more cooperation with the NGOs. Any follow-up? No? Ms. Rebecca Chen. Chairman, about this AMD or end-of-life care, we have been having a lot of discussions. The advanced medical directives, how are they going to be implemented? I think we should leave the details to the Bills Committee. What I'm trying to say is that for those units and organizations that are providing end-of-life care, we have the NGOs, they have the terminally ill homes, they have doctors and nurses, and also the end-of-life arrangement to be put in place. They are doing a pretty good job, and that would relieve the pressure of the hospital setting because they don't have to stay in the hospital. They can be moved to these institutions. But these institutions are trying to raise funds, like the Jockey Club palliative home. They have to rely on fundraising. The legislation will facilitate the passage of the patients. Would there be more support for these NGOs? I'm sure that would help the hospitals as well. Second, I'm grateful to the Secretary that in the paper you mentioned that there will be life and death education that will be mounted. This is a sensitive subject, and there is a court case recently, and the judge suggested that this should be really taken up. We have to deal with the irreversible life-limiting condition, like euthanasia. I'm not suggesting that you have to legislate for this, but I think you have to listen to the views of the family members and the patients when they're still mentally capable. Euthanasia is a sensitive subject, but I think it is time for us to engage in some discussion. Under Secretary. Thanks very much, Chairman, and thank you, Madam Chen. Cooperation between the healthcare sector and the community. There should be more cooperation in regard to end-of-life care, and there can be collaboration on more regular basis. Turning to the subject of euthanasia, I'm sure Ms. Chen is aware that this is two totally different kettle of fish. We haven't had enough discussion, and I don't think we should start talking about legislation. I think we can have some life and death discussion. It's only with sufficient discussion that we can decide how we take this forward. Ms. Chen, I think there should be more support for these palliative care institutions. They are running on very limited budget. They have to be self-financing. And regarding euthanasia, last year there was a court case in which the judge suggested this be discussed. Well, please do not follow up on this. This has fallen outside of the scope. I'll let you have a go at the first question. We have very limited time. Please follow up on the first question. I'm not asking for a reply. I'm not asking for a reply. Well, it is incumbent upon me to preside over the meeting. I'll let you have the first go. Please do not talk about euthanasia. Or I'm just saying that I'm grateful to the administration for starting the life and death education. I'm not suggesting that there should be legislation. Now, we should be given the time to speak. Mr. Peter Shiu, Chairman, Hong Kong people have the longest lifespan. We have a really good longevity. If senior citizens can look after themselves, the family members will still insist on feeding them, despite the fact that they have to be fed using tube. And some of them may be in terminal conditions, but family members would still sustain their lives. And these patients are in utter agony, and there is no hope, and it is in an irreversible condition. And these patients don't have the mental capacity to make the decision. And if you tell the patient before he becomes no longer mentally capable, he would have taken a different decision. And we are leaving these patients in absolute misery. So if we can allow these patients to take their own decision ahead of time and give the consent, I think I can subscribe to this direction. The medical care system is so good in Hong Kong, but one of these days people will have to go. I think it would be good for people to go without any agony. Now, regarding the AMD, who's going to be holding the document, Mr. Zhong raised all these scenarios. I've also seen some of these cases. The patient has decided against any resuscitation, but at the end of the day, the patient's mother suggested that resuscitation should take place. And I think that had it not been for the AMD, the argument would have been even more severe within the family. I think we should leave the initiative to the patients themselves. As to the AMD document, if we have a central registry, it would be more proper. If this is embedded in the ID card, for instance, we would readily know the decision there. Now, you say that people might want to opt out and there can be revocation. I'm sure that under this proposed system, you should listen to more views and you can certainly come up with a solution. With the central registry, it would be far better than a paper-based AMD, because these might give rise to confusion if there is any problem with the paper document. As to the opt-out proposal, people can have the opportunity to revoke and opt out. Dr. David Lam, Chairman, thank you. The spirit of the bill is worth supporting. I've got one recommendation. I hope that the AMD can be in written form, and people can still choose to have an electronic form. If I have this in paper form, I can destroy it. I can screw it up. What if I cannot find the paper document? If I leave it with my son and my son is out of town, what's going to happen? Now, you said it can be the original, it can be the certified true copy. What if I tear up the original and the certified copy is there? What's going to happen? Now, electronic version, people might find it difficult, but I think we have to educate the public about the e-version. In the mainland, a few would be unable to use the WeChat. If you can press a button and have this revoked, this is an option that should be available to the patients. Second, this is a question. After the consultation, the report suggests that the AMD proposal would be amended, or the AMD can be amended, and now there is no revision. Either you keep it or you have a new one. If you make a new one, you need two witnesses, one of them being a doctor. If I just have a minor amendment, the previous I just strike it out and sign on the dotted line again. Now, if I say that I don't want to be under intravenous injection. I want to have a catheter for urine passage. Is it possible? Third, it is also a question. In the paper, paragraph 13, in making the AMD, there is a need for 2 witnesses, and one of them being a doctor, and the doctor will make sure that the patient is mentally capable. I think we have to spell this out sufficiently clear. And we don't have to have a mental capacity assessment. As a surgeon, I don't think I would be able to do it. Most doctors cannot do it. If there is an argument, how can you make sure that someone has the mental capacity? What tools have you used? If I am hauled to the medical council, that doesn't make sense. And I hope that this will be spelled out. It would be a very easy assessment. Or if you're satisfied that someone is mentally capable, that would be good enough, which is beyond challenge. For a person, even if there are some problem with mental capacity, if someone is on high-dose morphine for pain relief, doesn't mean that he doesn't have the ability to make the decision. I think you have to make it more liberal there. 2 questions, 40 seconds, please. Chairman, thank you. Thanks very much, Dr. Lam. We'll certainly consider these points in detail. As to the paper-based AMD and central registry, I think we have to look at the storage. It would take time. If it is in paper form, we can certainly consider whether it is possible for a central registry to be put in place. We'll follow up on this. Mental capacity, I think we will address this. Mr. Edward Lau. Chairman, I support this legislation for advanced medical directives because this is respecting the decision of the patients. In many parts of the world, we see that the rescue workers will face tremendous difficulties. There may be the AMD, but the family members would insist that resuscitation has to take place. And the rescue personnel might be worried about the legal liability. But this law will provide them with a safeguard. Under the bill, if an AMD has to be made, we need to have 2 witnesses, and these 2 witnesses would not enjoy any interest in the estate of the patient, meaning that it cannot be a family member. And the family member may not be aware of this. He may be inviting a friend or a lawyer to be the witness. Now, when a rescue personnel is refraining from the resuscitation on the basis of the AMD, the family members might not be aware of that. How can you make sure that the family members will become aware of these arrangements and give the support so that the rescue personnel will not be put in a quandary? Undersecretary, I think Dr. J has already mentioned that in the AMD, it gives the directive, but this end of care is a project we have to discuss with the family members. In the AMD, the witnesses may not be a family member, but when it comes to the AMD or in the entire process, the family members will be part of it, although they may not be the witnesses of the AMD. Now, that's the proper way of putting in place AMD. What about any written form? All right, members who wish to speak have already spoken. I think we can bring these to a close. Thank you very much for being with us. Item number 5, any other business? I don't have any AOB items. Meeting is now adjourned. Thank you very much.